Welcome to the Health Trip Podcast. My name is Jill Foose. I'm a functional medicine and integrative nutrition health coach. I created this podcast to bring you along as we travel down intriguing, science-packed roads, debunking old medical paradigms and perusing new innovative therapies and modalities with the finest functional medicine doctors, practitioners, and like-minded biohackers while living our best life. Enjoy the show. Hi, everyone, and welcome back to another episode on the Health Trip Podcast. Today, my guest and I are talking about one of the most pressing issues in women's health during midlife, metabolic changes and how they shape the rest of our health span. If you've noticed changes around your midsection as you navigate midlife and menopause, you are not alone. By their 50s, up to 50% of women develop some degree of insulin resistance, and about 1 in 3 will be diagnosed with prediabetes. And these shifts don't just change the way we look, they raise the risk for type 2 diabetes, cardiovascular disease, Alzheimer's disease and dementia, and osteoporosis, and other chronic conditions that define our later years. That's why today's conversation matters. We're going to look at GLP-1 medications. You may know them by names like Ozempic, Wegovy, and Zepbound, and explore why they're proven to be so powerful for women in midlife and beyond. These drugs have been stigmatized and labeled as quick fixes or cheating, but the science tells a different story. They're not just about weight loss. They improve insulin sensitivity, they reduce inflammation, and they lower the risk for some of the most serious diseases affecting women in midlife and beyond. And importantly, we'll talk about how GLP-1s work hand in hand with menopause hormone therapy, body composition, and lifestyle choices to build long-term resilience. We're also going to cover FDA-approved drugs versus compounding pharmacies and all the nuances. Joining me today is Dr. Dana Russo. She is a physician specializing in women's health and metabolic medicine. She's a board-certified gynecologist, functional medicine physician, and the founder of Essenza Health, a medical practice dedicated to health optimization and transformative care. With over 2 decades of clinical experience, Dr. Russo combines precision medicine, advanced therapies, and compassionate care to help her patients achieve balance, vitality, and a longer life. And she's here to help us cut through all the noise and understand what the science really says about GLP-1s, why they're more than just weight loss drugs, and how they can fit into a comprehensive approach to our midlife health. Just a quick medical disclaimer before we dive in. By listening to this podcast, you agree not to use this podcast as medical advice or to make any lifestyle changes to treat any medical condition in yourself or others. Consult your own physician for any medical issues that you may be having. And this entire disclaimer also applies to any of my guests on my podcast. So sit back, open your mind, and let's dive into the world of GLP-1 medications. Hi, Dr. Russo. Welcome to the Health Trip Podcast.
Hi, thank you for having me.
Yeah, I am really excited for this conversation. There's so much noise in the metaverse about women's midlife body composition and metabolic health and menopause hormone therapy and GLP-1 medications. Now the combination of the two, which is definitely helping women achieve their overall health and longevity goals. But with the noise comes confusion and myths and hopes and skepticism as well. And so I wanted to start off with asking you, why is midlife a turning point for women for metabolic health and menopause symptom management goals?
Good question. I mean, midlife for women is not just about a variety of symptoms that women complain about and recognize in their body, but it is truly a metabolic shift. It is a metabolic shift in their brain health, physical health, metabolic labs, which often reflects changes in their body and responses to exercise, diet, metabolism, inability to lose weight. So, it is essentially a major metabolic shift, physiological shift that has implications on every aspect of a woman's life. And it can be a very frustrating and difficult time for women to navigate.
Yeah, because we're also navigating all of these menopausal symptoms, which are different for so many of us, and it's overwhelming. But the metabolic health landscape is really confusing to a lot of women because we've been taught to count calories, we've been taught to restrict, we've been taught to move our bodies more, or that this is our body is just broken. And so physicians like yourself, along with health coaches, are helping patients and clients navigate that journey differently now, reframe the way that we work towards our goals and understand our body.
Yes, absolutely.
So I help my clients understand their body composition data at the beginning of our time working together. Either I send them for an InBody or a DEXA scan, because many of them don't really even understand what body composition is. So I thought that'd be a great place for you and I to start the conversation here. So what does body composition refer to? And why is this something midlife women should be dialed into?
Great question. And it is something I address with all my patients too at their consultation and throughout their time with us. So body composition, I tell patients, is, when you step on a scale, you get a static number, and that's your gravitational weight, right? So it's going to give you one number. And what's important is to understand what makes up that number. What is your skeletal muscle mass? What percentage of that is fat, or pounds of that is fat? Where is that fat distributed? Where is it on your limbs, your trunk? Is it on your visceral organs, the fat inside your belly, not the fat that you kind of grab on the outside, the subcutaneous fat? What does your hydration look like? What does your muscle mass look like? Because those are the numbers that matter. Getting fixated on a total number is a really dangerous place to live. I will often say to patients, it's like when I check a lipid panel, I don't just check your total cholesterol. That's just one number. I need to know all the numbers beneath it that help make up that total cholesterol number. So, in my opinion, I think most people should throw out a traditional scale. There are ones that they're worth the investment, I think, at home, especially if in your midlife, to have looking at a body composition and monitoring your fat and your hydration and your muscle mass. It's key to longevity and your metabolism.
Yeah, I also think for women, how we used to think thin is the ultimate goal, right? A size 2 gene. And now we know that it's more about how much lean muscle mass do you have on you that's going to lead to an independent life for decades down the road so that you can walk to the farmer's market, grab all of your produce and your protein, walk back home, up a flight of stairs, be able to cook that without falling, without losing your balance, being able to open and close doors and lift heavy pots. To me, when I can help my clients reframe that into practical daily living, they start to understand it more and find more grace with themselves.
Yeah. Yeah. A sedentary lifestyle is a dangerous place to be in mentally, physically. We lose our muscle mass, we slow down our metabolism, we lose mitochondrial function. That's the cells inside our, a part of this cell inside of our body that is responsible for energy and our metabolisms. Where a big source of fatigue comes from when we lose that muscle mass. So being active and having the ability to do daily activities like you're talking about is not just about living your life, and doing things. It really has an impact on your overall health and longevity for sure.
Yeah, let's talk about sarcopenia for a minute because I don't think a lot of people really have ever heard the word sarcopenia. And if they have, they might not really understand what it means in terms of their health span. So, can you explain what sarcopenia is?
Yeah, so sarcopenia is the loss of muscle mass, okay, that has, a direct impact on our health. So we do start losing muscle mass even by the age of 30. And it certainly accelerates even greater when we are in menopause. The issue with sarcopenia is that our muscles are responsible for a lot. We just talked a little bit about how our muscles are responsible for a mitochondrial function, our powerhouses of our cells that give us energy and helps us with cognition and brain health. Our muscles are a big part of where we are capable of having insulin sensitivity or a lack thereof muscle. We start to get insulin resistance, where our body is not responding to insulin. and ignoring it. Our body's sending out more insulin, which is actually quite inflammatory. Could lead to hyperinsulinemia and weight gain. If left untreated and unrecognized, lead to pre-diabetes, diabetes, and unfortunately right now, about 50% of Americans are estimated to have insulin resistance. So sarcopenia, our muscles are responsible for sending out things that are myokines. They're chemicals that help us decrease inflammation and our neuroplasticity and our neural function. So muscles are beyond just lifting weights and lifting things. Their overall impact on our health is widespread.
Yeah, so I like to explain sarcopenia looks like the frail grandmother or great grandmother lying in a hospital bed who has no independent living whatsoever, who's just sort of wasting away. It's that muscle wasting. So once you give that visual, it's pretty strong for people to, sort of have this moment with themselves of, okay, what do I need to do to not go down that path? You mentioned labs a few moments ago that you like to capture one's full story of health by looking at more advanced labs like on the lipid profile. In terms of metabolic health, what labs would you want to see? And can you share what those numbers are going to mean if someone is, let's say, insulin resistant or moving towards that?
Yes. Well, my initial panel for my patients is pretty in depth. But when we're really looking at metabolic labs, we're taking a deep dive into their cholesterol profile or maybe even their particle size, whether they have, kind of big, fluffy, what we call them, kind of LDL particles that kind of move their way through, or lots of little ones. They have different implications on health. We take a deeper dive looking at certain lipoproteins like apolipoprotein B or AP little a. These both have different implications of risk for cardiac disease or genetic issues. So that's in terms of the cholesterol profile. When we look at more of insulin resistance in terms of that metabolic area, we're looking at glucose, we're looking at insulin levels, hemoglobin A1C, we might be looking at uric acid as well. That's not just about, people often think gout and drinking alcohol, but is very often elevated for patients who are having high sugar levels. So really to look at those numbers, like for a woman, we could go through some of them, like uric acid, for instance. When you look at a lot of these reference ranges, you'll see them on a lab, and they really are a bell curve of where average Americans fall. So especially in the functional medicine space where I work, we are often going, well, where am I supposed to be in this reference range? What is optimal? And that's where we spend a lot of time when we talk to our patients. Like, for example, uric acid for women really should be under 4.5, and yet you'll look at the lab and it might say up to 6 or 7 is normal. An insulin level in the morning for a patient should be low. Ideally, we shouldn't have eaten anything through the night, so we're not trying to break anything down. And really, I don't like seeing that anywhere higher than 5 or 7 in the morning, even though, for example, the lab will say less than 18 is normal.
Yeah.
When we start to even get a 10, you're really probably starting to look at insulin resistance. And glucose too. I mean, you really ideally want to see glucose under 86, even though the lab says up to 99 is normal. So we look at all these things, and I kind of explain these to patients, but you also have to look at the big picture. Sometimes those things are elevated when people are under adrenal stress or exhaustion. We also see those get, elevated. So, you have to take the whole picture of what's going on in the person's life and look at all the labs, but you kind of need to take a look at all those things. But those are some of the key ones we really look at, especially when we're looking at metabolic labs, in addition to also looking at like body composition and, bringing that into play as well.
Yeah. Yeah, it's very frustrating when you can start seeing your clients or your patients' trends going up throughout the last maybe 3, 4, 5 years. But if they're working with someone who's maybe within a healthcare setting, and they're looking at those normal ranges, things aren't really acted on. There's not a discussion. It's just you're in the normal range, nothing to worry about. Go on doing whatever you're doing. when perhaps things are not optimal and this person is experiencing symptoms, brain fog, fatigue, weight gain, sort of living the same lifestyle, but not seeing rewards, not seeing uh, goals being met. So that must be frustrating for someone like you in the functional medicine physician space.
Yeah, I mean, we definitely see a lot of patients, just like you said, who come in, especially when you get to perimenopause, menopause.
Mm-hmm.
Unequivocally, cholesterol will get worse, glucose, insulin resistance will go up. Very often, yeah, I do see it a lot. They're just kind of monitored and watched. But it's a very shocking thing for a lot of my women who come in menopause and go, what just happened to my cholesterol? It was never like that. Why did that happen? So we start talking about menopause and the implications of, and even their cholesterol could be an impact of metabolic dysfunction. So if we start correcting insulin resistance and weight, we see a correction in cholesterol and not going to directly only treating the cholesterol as a standalone issue. So,
Mm-hmm.
we try to incorporate the whole picture, instead of, for example, saying your cholesterol is elevated, we're going to put you on a statin, or we need to. But when you start to look at the whole, what they're eating, their exercise, the weight bearing, do they need any other assistance in supplements or medications to help them with insulin resistance? We could see great corrections in cholesterol and inflammatory markers as well. That's a part of the workup as well, looking at things like CRP or high sensitive CRP, which are looking for inflammation in the body. So
Mm-hmm. When it comes to going through the transition of menopause, what is the connection between declining estrogen and insulin sensitivity?
Okay, so there's a lot of things that go on with estrogen and insulin sensitivity. So estrogen, for starters, for women, is partly responsible to work on the hypothalamus in terms of our appetite. So when that starts to drop, women will start to have an increase in appetite. And so they will eat more generally. They'll
It's
have
that
an
food noise.
yeah, it's a real thing. It's a real thing. And I don't a lot of it, I think people just don't understand that there's real science and physiology behind it, that's
Mm-hmm.
not just being lazy or gaining weight. And so that's part of the food noise. And I've been doing this part of my practice, just focusing on perimenopause and menopause for 9 years. And even in my early years, patients would always say to me when their estrogen levels got higher, they're like, oh, I'm just not as hungry as I was. And I don't know if I quite understood that like really early on,
Mm-hmm.
but it was absolutely something that patients observed as we started to increase their estrogen. They're going, I'm just not as ravenous. Um, it has an impact on our estrogen that we're talking about, our insulin sensitivity in our muscles.
Yeah.
So that has a real big part to do with it as well. Um, so as well as, pardon me, fat distribution, very big deal. So when we go through puberty, for example, our brain tells our body to start laying down subcutaneous fat. So I tell people the fat that you could kind of grab and hold on to. So it goes to our breast, goes to our hips, goes to our butt, that's how we start to get our figure. When we go through menopause, we're losing that signaling. So the fat tends to get redistributed in different ways. So it tends to go to our abdomen, and increasing also to our visceral fat, the fat inside our abdomen or around our organs. And again, that releases something called cytokines, which are very inflammatory. That also increases insulin resistance for us. So we get this redistribution of fat that women, I tell people it's kind of a mean compensatory mechanism that happens, but it's not their fault. We just have lost the proper signaling from the brain. And so we get, you know, this unfair distribution of fat, which
The whole thing is unfair. The
yeah,
whole the whole thing is unfair. I mean,
yeah,
you've known me a long time and I have been dialed into my lifestyle since I was 16. I've always been active, always eaten a healthy diet, um, managed my stress as best as possible, raising 5 kids and going through a divorce. But, in the end, the fat distribution shift, the food noise increased. I gained more weight around my belly,
yeah,
harder to maintain my lean muscle mass. everything changed except my lifestyle. But then I realized I had to probably change my lifestyle to reconnect with the phase of life that I was in. And that's sometimes really frustrating for women, especially women who have been dialed into their lifestyle for so
Mhm,
long. And they say,
mhm.
I haven't changed a thing I've eaten. I haven't changed my sleep. I haven't changed my exercise. And I've put on, 8 pounds around my midsection. And then over the years, it just keeps
Yes,
accumulating.
yes, it does. Yeah, I mean, some of the data we've seen is that if that exact thing, women eat exactly the same, exercise exactly the same, sometimes a year into menopause, they'll put on 10% of their body weight. And sometimes when I do that calculation with patients, it is on point, you know, just 10%, and every year it's a little bit more.
Yeah.
And it is incredibly frustrating. But I think the thing that's important now is it was always the hardest part of my practice, even the early years, trying to get, hormones optimized and thyroid and looking at other things like vitamin D and B12 and magnesium and looking, adrenals, making sure they're appropriately supported. And it was probably the hardest part of my practice is really trying to help women, lose weight. I've, patients that worked with you closely, trainers that I know, and they would call and be like, she is doing everything. Like, I need your help.
Right.
I can't ask her to do anymore. Um,
Yeah.
and it's,
So if a lot of this is caused by the declining estrogen, progesterone, and testosterone hormones, is putting those back into our body the solution?
I wish it was that easy. We do have to replace those things because they're imperative for our longevity. I think it's probably the most important thing that women, provided they don't have contraindications, replace their hormones
Mhm.
like estrogen and progesterone and testosterone. But, they are important to replace. But unfortunately, in practice, we might see some shifts, but not enough to counteract the metabolic shift that happens and, the metabolic rate going down and metabolism. And it's just not enough. That has always been the toughest part of my practice and trying to find ways to make that work for patients. But I wish that was the answer. It'd be really, really simple. We could put them back on hormones and see all that weight come off. But
Yeah, I
it's
would agree. That
not.
wasn't my experience when I started taking menopause hormone therapy.
No, no.
Um, yeah, it's not the magic bullet. It's a combination of all of these things we're going to talk about today.
Yes,
Let's shift
absolutely.
over to the GLP-1s. What are GLP-1 receptor agonists and how do they work in the body? Because what some women might not understand is that our body makes this hormone.
Yes. So GLP-1 is an incretin, and so it comes out of our small intestine. So we'll talk about like what it really is before we get to the medications. So when we eat, we increase insulin, our small intestines will secrete GLP-1. It's actually a very short acting incretin, only lasts in our body for like 2 to 4 minutes to help us with metabolism or breakdown of food and sugar. So it is a neuropeptide, so it has many functions. So what we in science have tried to figure out is, well, how can we make this GLP-1 last longer? Do we find the enzyme to stop it from breaking down, something called DPP4? So that's the enzyme that's breaking down the GLP-1. So we've looked at some medications to try to stop that from breaking
Mhm.
down. And then what we have done and discovered in medications and getting past like in the early 2000s is these GLP-1. So we figured out how to make that last longer, initially with daily injections, and then what's become very popular is being discovered how to make them last as a weekly injection. So we could have these GLP-1s do a lot of different things. So what they do in the body, and the reason I found them so attractive was not that they were just for weight loss. They have really positive impacts on everything. So it is a neuropeptide, so we would do inject it or use it. It does tell our brain that we are full. It does work also on the um, reward center of the brain. So we do get some of that food noise go down. When we eat, we get fuller faster. So we know just kind of to stop. In terms of that reward center, which could be about food noise, like reaching for food because you're stressed or, that's your go-to if you're upset, or whether it's alcohol or a cigarette. We're having a lot of patients report gosh, I don't even want to drink that glass of wine, or I am not smoking as much. So it's one area that it works. It does make the pancreas kick out more insulin. So our insulin is available. So when we eat to break down our glucose or our sugar, um, it does lower blood pressure. So it helps the heart secrete something called AMP. AMP helps our blood vessels and our heart dilate and helps our kidneys excrete some sodium. So blood vessels dilate, or our pressure goes down. We release some sodium, we get out some extra water, so our blood pressure
Mm.
goes down. It helps our liver break down fatty acids. So we will see a tremendous drop in liver enzymes and fatty liver for patients. It does slow the gastric delay of food. So for two reasons that are beneficial to that, it makes us feel fuller faster, and that delay in moving the food also helps us kind of stop some of these insulin spikes. So, and then there is data looking at it in terms of neural function in some of the studies. We've seen patients have
Mhm.
improved neural function or cognitive function, which is really, really important, as well as even some improvement in heart function as well has been seen in some of the studies as well.
So why does our body is it that our body doesn't make as much GLP-1? Is it as we age? Is this genetic? Is it do some people make GLP-1 more than others?
That's a good question. Yeah. So we do start making less GLP-1 as we get older.
Hmm.
There could be a few reasons for this. One, by age, yes, we do make less of it. In younger people, it might compromise about 2 to 4% of their gut microbiome or their bacteria. Elderly patients, it may be like less than 1%. But that may also be a consequence of poor diet, not giving ourselves the food and the nutrients that we need to make it, or an imbalance in our gut, which we call dysbiosis, particularly missing a particular bacteria called Akkermansia, which is
Mm.
responsible for making the GLP-1. So there can be, but age, yes, it does decline, but unfortunately, our American diet is such a big source of so many of our chronic diseases. So, not having great bowel function and gut health is a big source of this too. And I think that's, a good reason why we see so much responsiveness to these medications for so many patients.
Yeah, I've read a lot on nutrition associated with GLP-1 production. And it's, protein helps, the amino acids help, the fiber helps,
Mhm.
um, healthy
Bitter.
fats help. Yeah,
Yep.
just a healthy dietary plate is going to help you. But that's hard for a lot of people
Mhm.
to accomplish every single day, right? So that's where like a health coach could come in and help them navigate that. But you have to be consistent. And even then, it's not a guarantee that you're going to increase your GLP-1 production.
Correct.
Because we already know there's a lot of midlife women out there cranking out amazing, healthy, whole food based meals, and they're still having trouble with insulin resistance.
Yes. Yeah, that's very true. And that's where I think they become very handy.
Yeah.
And for me, with my patients, that's definitely become a game changer. Like I said, it has probably been the most frustrating part of my practice, not having patients being able to lose the weight they want to do. I've often referred them to you and trainers and try to do the big picture, but I have been using these for several years in the practice, and it really makes a big difference. And I find them very appealing, not because it's just about weight loss. I never really actually given any patients anything for weight loss that have been in the market just purely to speed up their metabolism or suppress their appetite. That just never made sense to me. I mean, I understand why it would make people lose weight, but when I can look at this and go, okay, I could lower your cholesterol, I could lower your inflammatory markers, I could drop your blood pressure, I could
Mm.
take maybe some cravings out. I mean, even patients for our biggest addiction in this country is just sugar addiction. I have
Yeah.
so many patients that literally can turn away from sugar and have an appetite for healthier food. So these became very appealing to me when not only I could help the physiological issue of, or physical issue of the weight gain that women were so unhappy with, but we could just literally shift all these metabolic labs and issues. I think they're great. I do think they just need to be monitored closely
Yeah.
with patients, and done in the hands of someone who's going to provide some continuity care to monitor them. But you need,
Yeah. So because I know how you work with GLP-1s, I really can appreciate how you have your patients do in bodies at certain before, during, and if they're on it long term, you're monitoring that in body body composition the
absolutely.
whole way through.
Oh, absolutely. Yeah, I think it's important for patients, and it's definitely a process too, right? It's a
Yeah.
process, not just physically, but mentally for women
Hmm.
to, gosh, we've seen our bodies go through so many shifts, go through puberty, then pregnancy, then postpartum, then maybe a pregnancy again, or however,
Right.
2, 5, we've seen our bodies go through these metamorphosis, and it's a lot. It's a lot to mentally kind of see happen to your body, but especially when you get to menopause and this waking comes on, and it's not just that. I mean, your mood is low, you're not feeling well, you got a low libido, there's all these other physiological changes that are going on. It's just another needle in the haystack. So here with patients, I think because we spend time going over nutrition and protein and sitting down at their visits and getting them on the InBody and them getting used to looking at that scale and just not being obsessed with that total weight
Yeah.
and redirecting their focus onto looking at their muscle mass and looking at to their amount of pounds and fat they have or percentage of fat. And they really tune into that as well as hydration, because that has a big impact on how your muscles may look on a week to week basis. So, for example, if a woman comes in really, really dehydrated and she's super active, it might look like she lost a pound or so of muscle, but really you could see by her hydration, she was really dehydrated. So
Yeah.
it becomes a great learning process for patients for them to really see their body in a different light and respect the different parts of their body that make up the whole.
Absolutely. And I think it's important for them to see that their lifestyle is the foundation for everything and whatever they choose to do. And going on a GLP-1 means that you're going to have to be much more intentional about your lifestyle, managing your stress, lifting weights to avoid losing lean muscle mass, which so many people do when they take a GLP-1, if they're
Mhm.
not being monitored by a physician who's dialed into that, or they stop eating right. They You have to be intentional. And I work with so many women who are on GLP-1s. You have to be intentional about building a nutritional plate, focusing on that protein, focusing on all of the healthy carbs, your fruits, your vegetables, your grains, all the good things, right? Um, so I think it's a not a quick decision to make to go on a GLP-1. This is something um, that you as a physician really look at the full picture, the full story of here's what your lifestyle is going to need to look like to support the the success of the GLP-1 medication.
Yeah, yeah. I think we go through it with a process with patients here and they come in. We do go over a lot of time going over hearing what's going on with them, going
Hmm.
over their labs, and prioritizing what things we need to do first and in what
Yeah.
order, and really so they can see the difference of, what we do, whether we're just adding in hormones, their sex hormones first, or optimizing their thyroid, or restoring their adrenal glands if, those are really exhausted, so they could feel the difference and the benefit of recuperating all these systems and then layering everything in. Before you get to the GLP-1s, you have to
Yeah.
talk about, their diet and their exercise and, or do they have insulin resistance and what does that mean? And, why is it making it so difficult? So it's a very layered approach here because
Yeah.
it could be very overwhelming. And a lot of women have these issues. So without overwhelming them, but just giving them time to process everything that we're going through, making the changes. A lot of women feel very, very unheard that sit in my office. They get very, very emotional, when we talk about what they're feeling, and that there are things to do. They feel very, very validated. And so it's a quite an emotional process for a lot of patients that,
Oh,
care and work
absolutely.
through it.
Yeah.
So it's very rewarding, but it's a lot for them to kind of take in and understand, but it's very
Well,
rewarding.
I just love that there are options. I mean, women deserve a plethora of options in all facets of their lifestyle. I want to talk about microdosing GLP-1s because that is all the buzz right now.
Mhm.
So maybe you could share with us what the FDA approved um, m- dosing is for a GLP-1 versus microdosing for someone who might not fall under that FDA approval.
Yeah, sure, absolutely. Because there's so much in the news and the media
Yeah.
about this. I just wanted to backtrack because you said something that made me think, and even before we even get to GLP-1s and stuff, there are even other supplements that work, having options for patients. I think that was a great comment. I just wanted to reiterate that because sometimes there are great supplements that could help support
Mhm.
patients too, that they don't have to go this route that they respond to. So, it's not a one size fits all for everybody. So the GLP-1s have gotten so much attention. They're very, very popular. They've been around since 2000, I think 9 was the first, but what became really popular was in 2017, Wegovy, or Ozempic, excuse me, got FDA approved for diabetes, and it was very appealing because it was once a week. Um, and then eventually it came under the name Wegovy, which got approved for non-diabetic weight loss. And then we have trizepatide, which is Manjaro and Zepbound. And then that was the not, I shouldn't say second generation, but that was another GLP-1 agonist that also has something called GIP in it. So there's two different peptides. So what really happened and has been going on is that there was great medication doing really well, and there were shortages of the medications. So when there is a shortage, a national shortage of a medication, a compounding pharmacy or outsourcing pharmacy can make the exact same drug and the exact same dose for patients. It's a good thing. I mean, when I started my practice, lidocaine with epinephrine was, in shortage and back ordered. So the compounding pharmacies made it, and I was able to get access. And there are different compounding pharmacies too that we should probably talk about. There are, you know, I don't want to say regular mom and pop, but there are some smaller ones. There are bigger ones which have something called a 503A, and that's where they could make medications and distribute them directly to a patient. They're patient specific. Then there are larger ones called 503Bs. They're outsourcing facilities, so they can make bulk medications like the lidocaine with epinephrine I was just talking about, and distribute it to physicians and hospitals and facilities. So especially when you start talking about these ones that have 503As or 503Bs, the 503Bs are FDA registered facilities. So they hold up the same good manufacturing processes of other
Mhm.
drugs. So you are getting a very tightly controlled medication. And the FDA in those circumstances are aware they're making these medications. So there's been some back and forth as whether there's been shortages and lifting those shortages and saying that compounding pharmacies are not allowed to make them anymore. But a compounding pharmacy can make any FDA approved drug. However, if it's not on a shortage, it has to be in a different form, perhaps a different dose that's not commercially available in a store, like a pharmacy to pick up, or it is mixed with something else. So you still can get GLP-1s, but they're usually, you get it in a different form or a different dose than commercially available.
Wait, so
So
when you say a different form, if you can get an FDA approved injection because you have type 2 diabetes, for example, and then a compounding pharmacy goes and makes a similar or the same drug that's also an injectable, that's still the same form.
but a different dose, but they're making it totally different doses. So that's how they could do
Oh,
it.
so it can be in the same form, but it has to be a different dose.
Different dose,
Got
right?
it. Okay.
Yeah. So like say, for example, some of my patients, there are some patients who have progesterone intolerance. They just don't do well.
Hmm.
And the lowest dose that I could pick up a micronized progesterone at Walgreens or CVS is 100 milligrams, and maybe they need 75, or instead of 200, maybe they need 225. You could get that
Hmm.
compounded. So, which leads us to, I think, your conversation about the microdosing and what is it.
Mhm.
With both the medications, they have what they consider therapeutic doses. Like on semaglutide, they actually consider the therapeutic dose a milligram, and I think it's 7.5 for the trizepatide. But microdosing has gotten a lot of buzz is because it's using a sub-therapeutic dose, and in my experience, especially with women, getting benefits. So say, for example, the starting dose for trizepatide or Zepbound and Manjaro is 2.5 milligrams. We actually start patients on the women in our practice in particular, on a lower dose than the 2.5 milligrams, the initial dose. And we find in this practice that these women are actually really losing weight at a slow rate too, which is really important, that they're only losing weight at like one, and I really don't like patients to even lose as much as 2 pounds a week.
Mhm.
Once it's a
Mhm.
marathon, is slow and steady. The studies were
Yeah.
over a year. They weren't, losing 20% of their body weight in 4 months. That's
Right.
not what we're doing here. So microdosing, we have found starting patients at really, really low doses. They do really well. They do lose weight slowly. We see inflammation come down. We see very minimal side effects. The other benefit is we could also just kind of taper up their dose in smaller increments, if they're, buying a vial of it compounded. So we get to really tailor that medication to what suits them best and their needs.
Yeah, what you mentioned side effects, and we didn't talk about possible side effects. So, what are some of those? And I can see how the lower microdosing would reduce those because I've worked with a lot of people, including men, who are taking the FDA approved dosing and they cannot eat. The food noise is shut off so bad that they're nauseous and they really struggle. And I just see the weight coming off them, and their physician, who's not you, by the way, is not doing an in-body, is not monitoring their lean muscle mass, which they lose. So it's really hard to get them to consider a healthy lifestyle, all the pillars of health, when they're feeling nauseous all day and have zero appetite, and which leads to zero energy.
Yeah, and then you just get into the muscle loss. Yeah, I mean, most common side effects of the medicine, very common, can be nausea, heartburn, fatigue, constipation, more often than diarrhea. So, um, if done it too high, and appetite suppression, it's a purpose of the medicine, but I would call that a really bad side effect. If you have really, someone said, God, I didn't even want to eat till 4 o'clock. Well,
Yeah.
that's too high of a dose. You're supposed to have somewhat of, some suppression of your appetite, but I tell patients, I still want you to want breakfast, lunch, and dinner. I don't
Right.
want it to be 6 o'clock. So if you're not eating, then you're not getting any nutrition. That's when you're losing your muscle mass. That's when we see things like hair falling out. So, losing muscle mass and your hair falling out, or Ozempic face that people talk about, that's from too much weight loss too fast. Your
Yeah.
appetite suppressed, you're losing nutrition, you're losing the fat, you could get medications can make you dehydrated as well, not even want desire to drink. So we have to
Hmm.
focus on that a lot for our patients to make sure not only are they drinking, are they getting in a good amount of electrolytes to support their hydration. So those are more of the common side effects. There are some that have seen from more for patients with, which we're not managing, type 2 diabetes, um, gastroparesis where the bowels really stop moving, or pancreatitis or gallstones. So those are some more severe side effects that have been seen with the medications, but not an issue for us in this practice, I think, because we just take things slow. And I agree with you. I just don't think it's a medication that should be um, prescribed and not followed up, because then you're going to miss those signs to talk to somebody about their weight or their hunger or lack thereof. Um,
Hmm. Yeah, absolutely. And this is a time in our lives where we really need to be vigilant about getting in that protein,
Yeah.
hitting that daily mark for us, whatever that is for you that's optimal, making sure that that is non-negotiable, making sure that bringing in lots of different sources of fiber, non-negotiable, unless of course you have issues with fiber. But for
Right.
most people, um, I would say, we know our gut microbiome goes through changes in perimenopause. You already alluded to the fact that the gut microbiome changes so that we are enabled to produce this GLP-1 hormone um, optimally. And so, yeah, the microdosing makes a lot of sense. Who should consider this GLP-1 microdosing pathway?
Well, I mean, the FDA, to start off, the FDA um, guidelines are for diabetics and non-diabetic weight loss in terms of it being covered and recommended. Let's talk about like you know, it's recommended for people with a BMI over 30 or 27 with a comorbidity like hypertension, diabetes. I'm going to throw in a little caveat there because I don't love BMI as a metric
Mhm,
in general. So we'll talk about that because BMI is really just taking into account someone's height and weight and coming up with a calculation. So, if some guy is 6 feet tall and a bodybuilder and 180 pounds and, you know, 5% body fats, or if he's, 6 feet tall, 185 pounds, and he's a couch potato and all fats and very little muscle, they're going to have the same BMI. So
right,
in
right.
general, we talked about body composition. It's not a great metric, but that's where it is. But then, and adding on to that, sadly, we're just actually seeing some insurance companies aren't even covering it now unless they have a BMI of 32. So there's an insurance issue with coverage there. But who else should take it? Patients that have insulin resistance, um, that are struggling with weight for sure. Um, Patients that have inflammatory issues, we have used it with off-label, perhaps patients that have polycystic ovarian syndrome, because that goes
Mm,
along with insulin resistance as well. Um, we have used it for patients that have very successfully in this practice who have had non-alcoholic fatty liver disease from insulin
mhm,
resistance. And we have nearly reversed the fatty liver in 3 of our patients. So that's another subset of patients. Um, and I sometimes use it and offer for patients who are struggling. They just recently had a surgery, a back surgery or knee surgery, or they have an injury and they're waiting surgery and they're trying to get the weight off, but they're slightly immobilized because of their injury. Done in the right way, I think it could help reduce weight for some of those patients, and reduce weight bearing issues on their joints, knowing that we have a goal to getting them mobile, but
mhm,
it helps them even preoperatively. Um, I like to talk to patients when we see elevated cholesterol and insulin. Okay, so we're talking about those patients as well. We've had some conversations with patients who, have used them and come back and say, you know what, I didn't even want that glass of wine, or I cannot stop eating sugar. Like for the life of me, I can't, which then leads to weight and metabolic issues. But those things work really, really well for patients as well. And we have very honest conversations. These are
yeah.
off-label indications, right? So we're very clear with our patients. But there are some very interesting studies looking at patients and their role for decreasing cancer. There's some information that was reported at ASCO about decreasing endometrial cancer and ovarian cancer. There are some studies looking at its prevention and help with Alzheimer's and dementia.
Mhm.
So there
It's
are,
like the jack of all trades.
it is, but it is,
Costs a
I
lot
think
of
it's
money.
very good. It does a lot of great things, but I just think
Mhm.
it has to be monitored really closely.
Yeah.
I just don't think it's one of those prescriptions, but yeah, it has a profound effect on a lot of.
Is microdosing a GLP-1 long term, or are there situations where it could be a short-term temporary approach?
I think it depends. Lots of times it is long term, but it depends on the patient. So we have, depending on what's going on with the patient, a lot of our patients are menopausal, so we should talk about that too in studies, is that especially if you're talking about a menopausal patient, you really need to talk to them about hormone replacement. There are really great studies demonstrating the benefit of these medications are significantly better when you use menopausal hormonal therapy.
Mm,
So both with semaglutide and tirzepatide. So that has been proven in studies. So when you're talking about using these medications, especially for these women, you need to talk about starting menopausal hormonal therapy, and then whether they need to be them on long term or not. Yes, there is, data saying that if patients lose weight and come off of it, there is can
mhm,
be some rebound and weight gain. That is true. And certainly if there's more weight loss, they stop them in a year, that portion of that weight can come back on, probably because there's really bad metabolic dysfunction. So you do have to talk to patients about what they're going on it and what's the reason. And is there a family history of diabetes and insulin resistance? Well, then yes, this might be a long-term medication for them. And sometimes we could taper that dose so we're not losing weight. We're just getting a dose that is keeping their metabolic labs stable. So that's a very, real possibility for patients. So you have to tell them that is possibly the situation.
mhm. With so many pop-up places, I mean, we're both in the Chicagoland area, and there's just pop-up places that offer GLP-1 medications, but there's also places online where you can get them. What should women look for in terms of red flags before going down that pathway?
The red flags for me would be the maintenance portion. Is anybody, holding them accountable for body composition? Is anybody checking in with them to see what their appetite is like? I get really concerned when I see ads that say lose 10 pounds in the first month.
Mhm,
It's way too much, way too fast. So I think the most important about any online maintenance is really what is the maintenance? What are they doing to monitor you? That is really pivotal because it is completely counterintuitive to make a woman lose weight, which is something she's not happy about, but then to make her lose muscle mass.
yeah,
So you didn't do her any good.
right.
You just did more harm. So you may have lost weight, but having her lose her muscle mass is completely counterproductive to your goals of longevity and lifestyle and healthy living.
Yeah. What would you say are some questions that a woman should ask a physician she's going to see about taking a GLP-1 medication?
Good question. I think they should be asking about the physician's experience with it. I think they should be asking like some of the things we talked about. How are they going to be monitored?
Mhm.
What their goals are? Is there any support system for them in the practice to discuss their nutrition and exercise? And if not, do they have someone to help recommend to do that with them? Um, and what are the short-term and long-term goals of the medication?
Mhm. Yeah. Is
Yeah,
there anything else we left out about a GLP-1 medication and menopause, and the connection between the two?
good question. I don't know. I think we covered a lot.
Yeah, I think we did.
I think we
Yeah.
did. I'm trying to think of all the other things that we talked about, but I feel like we covered a lot of our bases.
Yeah. I think the take home message here is one, work with a physician who is well versed in uh, using these GLP-1 medications, and also working with someone who's going to hold you accountable to that healthy lifestyle. Those
Yeah,
are the two main takeaways.
yeah. It has to be about everything, right? It has to
Yeah.
be about the diet, the exercise, lifestyle stresses, sleep, menopausal hormone therapy.
Yeah.
Um, I think making sure beyond the invite, physicians are, looking into, we talked about DEXA scans, but their bone densitometry, how
Yeah.
strong is their bone health as well, because that's really, really important. So,
Yeah.
yeah,
Do you see anything coming down the pipeline for women's health in terms of metabolic function, um, that's interesting and noteworthy?
Well, there's in phase 3 clinical trials, there is another GLP called retatrutide. So that one has 3 peptides that are in it. So like trizepatide has a GLP, GIP, and then it has a glucagon agonist. What's interesting about this one, and we'll see from the initial studies, is that that one seems to be having a big effect on direct lipolysis, which is the direct breakdown of fats.
Mm-hmm.
So what they're seeing, and we'll be hopeful to see, is they're seeing like 24% weight loss over, I think, 48 weeks. So semaglutide was the first weekly one that was about 15%, but that was done over a year.
Mm-hmm.
Then trizepatide, it was more like 22%, but again, that was done over the course of a year. But what's interesting about this one is that it is more weight loss in a shorter period of time, but because it seems to be having a direct breakdown of fat, it seems to seem like there is a preservation of muscle mass. And when we have a
Mm-hmm.
preservation of muscle mass, we're preserving our metabolic rate and our metabolic function. So that would be really exciting to see. So, we should be hearing more about that one in the fall, but the initial data is looking really promising. And I think this is what we're just going to see, um, just really optimizing these medications. What I would really like to continue to see the studies is, the other benefits beyond weight loss, like cancer prevention or
Mm-hmm.
dementia or cognitive decline, because dementia is just like a type 3 diabetes of the brain. There's insulin resistance in the brain and it's not functioning well. So I think it would be really exciting and promising to see further studies with these medications.
Yeah, I was reading about that drug and the trials going on, and it sounds really promising and
Very
very,
promising.
very interesting. So thanks for
Yeah.
bringing that up.
Yeah.
Well, Dr. Russo, thank you so much for joining us today.
Yeah. Thank you
I
for
love
having
this
me.
deep dive on the GLP-1s. It's a topic I haven't covered yet, and of course, I get asked about it all the time. And it's really interesting. And to me, it's like I said, we deserve all the options, and to be able to pick something that aligns with our greater health goal and our lifestyle. So this was a wonderful conversation with a lot of golden nuggets to take away.
Thank you. Yeah, I enjoyed it too. Thank you for having me. Always
Yeah.
love talking to you. All
Yeah. Thanks for tuning in, everyone.
right. Take care.
Thank you for joining me. I hope you enjoyed the podcast. Lifestyle changes can be hard and overwhelming to make. By building your support team of functional medicine doctors, therapists, and health coaches, you can reach your optimal health goals. Be sure to check out my other podcasts. Until we meet again, stay healthy.